knee replacement and revision surgery. And I would like to share a little bit of that today. Now, this first little talk is really just about patient-focused surgery. And it is really every time I see a patient, they come to me either with pain or dysfunction. And my job as an orthopedic surgeon and a doctor is then to figure out what their problem is. So, as you know, we call that making a diagnosis. And what you will learn at Stellenbosch would be that the basics for the last 100 or 200 years in medicine is that 90% of the information you need to make a diagnosis is from a thorough history and a good clinical examination. And then you augment that information with x-rays and other special examinations like MRIs and CT scans. And then you come to treatment options, and that is where you then balance the risk and the benefit to the patient to decide what their better options would be. Now, today I would like to make it more practical and share a few patients with you to make it real. So my first patient is a 74-year-old male. He had both his knee replaced. He had no pain for the first year and a half, and then he developed more pain, and he had a few surgical procedures and stayed painful, stiff, and dysfunctional. Now, this is the x-ray that I saw of his knee replacement, which immediately showed me a few things going back to basic anatomy and also the knowledge of modern knee replacements. So I could quickly see that this guy had a very poorly designed, constrained hinge knee replacement done. His joint line were moved down. His patella was sitting too high. His posterior femoral condyles reflects that joint line being misrepresented, and then osteolysis of the tibia, at least. I managed to revise his knee by taking all that components out. There were broken polyethylene liners, a piece of metal in, and it became clear later that this was a locally manufactured knee replacement that wasn't very well designed and tested, and I used a well-designed revision knee system that has a lot of different options to the surgeon to recreate more normal anatomy, more normal ligament balancing, and ending up with a painless knee replacement. Another short one is a 90-year-old guy who had a hip replacement and were getting progressively more pain with weight bearing. He was actually a very talented guy. He was a musician. He taught at the Cape Town University in music, and that was his passion. He lost his wife, and his relaxation was to walk in the evenings for a kilometer or two, and finally couldn't walk anymore. He had a hip replacement 40 years ago and had x-rays done 3 years ago, which was reported by a radiologist as normal. His family doctor thought the radiologists were right. And that was the x-rays that he had when he became symptomatic 3 years ago, which clearly showed an old Charnley type hip replacement with loosening and osteolysis of both his components. Now, at this stage, it would be very easily treatable with very easy techniques using the old cement mantle on the femoral side, and putting a revision acetabulum component in without doing osteotomies to bivalve the femur to get the cement out. That is unfortunately 3 years later, where it almost looks like a giant cell tumor around his hip with migration of his acetabular component, and as you can see, some of his femur disappearing. Now, this necessitated a major reconstructive procedure. Our third patient, 57-year-old female, sudden onset pain, had x-rays in a very benign examination. She had her other hip replaced a few years ago, and the left side were painful, but she had essentially normal x-rays. But clinical examination revealed pain with motion of the joint. She had a diagnostic injection of local anesthetics into a joint that relieved her pain. And intraoperatively, she had a horrible looking femoral head that didn't reflect the severity of her arthritis on the x-ray. And she was very happy and relieved with a modern hip replacement. And another patient, 27 years old, right hip pain. Unfortunately, he was in a car accident. He fractured his pelvis, which healed, and he had ongoing hip pain and had a few arthroscopic procedures to repair his labrum. The arthroscopic procedure was done by one of Cape Town's experts. He is very familiar and technical, sound, but this patient had ongoing problems with his hip. This is the x-rays that we took at that stage, which still showed subtle signs of impingement. Now, on a side note, when I studied medicine in the 80s, still 70% of osteoarthritis of the hip were idiopathic, which is a fancy name just saying that we didn't know why people would get arthritis. Now, everyone has a diagnosis. It's either inflammatory or either due to hip dysplasia or impingement, whether it's habitually impingement or torsional deformity. But now we can always tell someone why they have pain, when they could still benefit from a joint preserving procedure, and when they would do better with a hip replacement. Now, I felt that this patient could still benefit from a joint preserving procedure and chose an open procedure. So this would be the surgical dislocation as described by Reinhold Gans that all came from his daughter's vascular studies, allowing us to safely dislocate the hip, then examine the acetabulum, the labrum, and see the area of impingement and do the necessary osteochondroplasty at the femoral head neck junction and or an osteotomy either inside the capsule and joint or outside the capsule and joint. Now, this patient needed that dark area on the head was an area that still impinged. Towards the left of the head, where my finger is, you can see that that is where his arthroscopic head neck recession were done, but it was clearly not circumferential and adequate. And the more complete head neck recession, which would be the really red area at my sucker tip, now shows the more aggressive head neck recession, which rendered the patient now pain-free, allowing him to ride horses, farm, walk, and not have pain. So with the hope of saving his joint for another 20 or 30 years. One more patient that had a femoral neck fracture, which was misdiagnosed as a contusion. He clearly had a displaced femoral neck fracture, which wasn't treated. I arranged for an MRI of his hip to confirm that his head was still vascular and could do a joint preserving procedure to essentially put the fracture site at a more horizontal position to the floor by doing an osteotomy, putting the whole proximal femur in more valgus, so in such a way loading, exposing the fracture to better forces, which allowed not just the osteotomy, but also the fracture to heal. So we use different approaches. The small little guy on the right is me, and the guy on my left was a professional football player in Canada. He had arthritis of both his hips, and I replaced both his hips within a year. He couldn't get up from a chair or walk upstairs. Fortunately, he works in the computer industry, so he doesn't have to walk much. But the posterior approach that I use in the modern posterior approach is reliable, quite bone preserving. We can respect the muscles attaching to the proximal femur, and it's extendable. So we often see complex deformities in younger people, which need a bigger approach to deal with the more complex procedure without tearing and hurting the muscles, which then affects their pain and function afterwards. So I needed hip replacements when I was 50 years old. So that is just a little example of me within a year after my 2 hip replacement surgeries, through posterior approaches with dual mobility hip replacements. So we'll talk a little bit about the modern technologies of hip replacements shortly. Very important, I think, for young people doing medicine is being serious about your studies now. So still one of the most important things that I use every day when I do surgery, when I plan my surgery, is anatomy, osteology, and biomechanics. So that is the subjects that you learn now. And if there's one thing that I wish, is that I studied that harder and understood it better when I was 22, rather than struggling to learn all those principles when I was 40. So I plan all my surgeries. So my team that work with me, especially the guys in the medical industry, they always feel comfortable and supported when they see that my preoperative planning were done weeks ahead of time, which allow them time to make sure that the appropriate sizes would be there. There's fairly easy and straightforward joint replacements and very complex procedures that needs augments and specialty implants and tools that we use. So very important for me to plan my procedure in my office and to essentially execute my plan in the operating room. So I kind of likely would say is I don't like to think in the operating room. I like to do most of the thinking in my office. So it is important in modern hip replacements to really respect the biomechanics and the soft tissues to treat a patient's pain, their arthritis, their weakness and dysfunction of their muscles by removing the necessary bone, but no more, to mobilize the muscles without hurting them, and to recreate healthy and positive biomechanical environments. So soft tissue balancing is really to put not too much tension on the muscles, but in the right position, which doesn't just create stability in a hip replacement, but also optimize the function of the hip abductors. The hip center is crucial in this planning, and lots of research has showed that by manipulating your hip center will create the best pain scores, but also longevity in the replacement. The appropriate torsion and offset also crucial in the soft tissue balancing and also the muscle function, the scores. And we are really trying to achieve modern hip replacement with modern approaches that will give patients the best possible function for the longest possible time. So I use good quality calibrated x-rays. We now have software that helps us to do this on the computer. Still, the most important initial investigation is a good regular x-ray done appropriately in a standard fashion that is calibrated. So I had a meeting with our x-ray tech today, just again to go over all the important principles of getting the right x-rays for me to do the appropriate planning and templating. So there's different tricks and ways to do it, like shows for the real importance of teamwork, working with all the teams that participate in your patient care to get the right information and the small things done accurately. Your planning and your surgery can go well. So here is a few basic lines that I use to look at leg length discrepancies, offsets, the anatomy, and then the hip center. And I will just quickly run you through a few x-rays and markings, how I planned some of these surgeries. So the little green dot in the middle is the hip center. The 45-degree angle is what I plan on putting the acetabular component in that degree antiversion. And the measurements is just to draw that over to the normal or abnormal side to see where and how I want to manipulate the hip center when I do my preparation for the replacement. So that is the execution of one of these hip replacements in a young person. She needed the other side done fairly soon after the first side. And again, just running it through my planning sequences. So number 4 there, where it said respect the psoas tendon, is a little technical pointer. A lot of people that has hip replacements will have groin pain when they walk upstairs, which is directly related to the psoas tendon being irritated on the anterior rim of the acetabular component. If this didn't take exceptionally good care to position the acetabular component inside the bone where the psoas tendon crosses the joint. And there's just a few more of that as an example. So the first few was fairly straightforward hip replacements. This patient had slipped femoral epiphyses. As a child, he had a surgical dislocation and an open reduction of this slipped femoral epiphysis on both sides. He failed the procedure on the left side and ended up with an intertrochanteric osteotomy that failed and became non-united and later malunited. And he was basically unable to walk and to work. Again, coming back to basics, I needed to go back to the biomechanics of the leg and the hip and worked out where this patient's hip center needed to be from the acetabulum side, but also how to position his whole deformed proximal femur to align that with his knee and his ankle, to finally get a revision type hip replacement to combine a hip replacement and a proximal femoral osteotomy to allow him good function and success with this complex procedure. So I templated off of his more normal side, looked at my calculations from my biomechanical principles, and went ahead and approached his hip through that surgical dislocation approach, redirected his proximal femur, and put a revision type stem down his intact distal femur, and managed to recreate a well-balanced, stable joint replacement with the center of his hip at the appropriate spot to put tension on his hip abductors, which allowed him to heal his osteotomies, now to walk without crutches and have strong hip abductors. So this is also a more challenging case, not just to execute, but to understand and to plan. This patient has hip dysplasia and unfortunately didn't get a joint preserving procedure. She could easily have had a periacetabular osteotomy to cover dysplastic femoral heads, which would have prevented her from getting arthritis. So she now already does have arthritis, with both the hips being sublux superiorly and laterally. So again, with these principles, I could template where her native hip center should have been, where the center of her rotation on the femoral component needed to be, which component I could use to adjust my anteversion, and saw that there will be no roof to cover the component. So I needed to use a part of her femoral head to graft, do a structural autograft of her bone to support the acetabular component. So you can see now that her left leg there is not sublux. If you follow the calcar of the femur down to the pubis, the center of her head is more or less at the height of a greater trochanter. But now you can see the huge leg length discrepancy she has, which we needed to correct when we did the other side. So she used a shoe lift on the one leg until she was ready to get the other one replaced and now has a balanced, functional, pain-free hips. She's also much taller, and now all her miniskirts are a little bit too short, but she doesn't mind that at all. So bringing us a little bit to the history and evolution. So this knee replacement surgery that we do has been coming on for hundreds of years. It has been gradually improved, but hasn't changed much in the last 20 years in the design of the implants. The improvements then came with the instrumentation we use to do these surgeries more accurately. The different philosophies, measured resections where you measure how much bone you remove. Then there is methods to look at the soft tissue balance and stability. And over the years now, we're at a stage where we have great implants, many different sizes, fantastic bearing surfaces, modular components, and better materials that enhances the bearing surfaces that creates longevity of these implants. Now, years ago, my mentor were asked by the New York Times, after he did his fellowship in London, how long does modern joint replacements last? And being a professor and an academic, he paused and he said, indefinitely, but I have to qualify. And he then went on to say, if a knee replacement or a hip replacement is done with the proper components and material, done properly, respecting the anatomy and the biomechanics and the soft tissues, and the patient are willing to follow up for scheduled, structured follow-up appointments, should we see any reasons why this joint would catastrophically fail, that we could intervene, change a liner. If there's an injury with a scratch on the head, then it could be replaced, almost like if you get your car serviced. So we also improved in rehabilitation, supporting patients, helping them to get the joints moving, understanding the principles, not trying to walk without crutches too quickly, to respect the pathophysiology that occurs around a hip and a knee replacement, to allow sufficient time for the muscles to heal and support normal muscle function before people start walking without their crutches. Also, we're better with our pain management, our anesthetics, and we saw that our patient population is changing. 40 years ago, the patient on the left was the ideal candidate for a hip replacement. The guy on the right wouldn't qualify. Now, as you know, there's young, active, professional sports stars that would get hip replacement surgery and go back to compete at a world level. I'm sure you know that's Mr. Murray. So the evolution has broadened. Our options are now significantly more, which enables us to do compartmental replacements, whether it's a medial unicondylar knee replacement, a lateral unicondylar knee replacement, a patellofemoral joint replacement. Then from a very conservative full primary knee replacement that keeps both the anterior and the posterior cruciate ligaments, sacrificing the anterior and then sacrificing both the cruciate ligaments, And all has their pros and their cons, but we have these options. You can see the polyethylene liners, or the white pieces, would be modular. So that could be removed and replaced in 15 or 20 years should there be wear issues. In people with very severe arthritis, bad bone loss, ligament injuries, soft tissue envelopes that cannot be balanced, we have more constrained options. And also when we revise primary knee replacements, that hasn't followed up and wasn't dealt with in a timely fashion, we can now make up for these deficiencies with more complex revision type knee replacement implants. Surgical execution will always be important and would complement all these evolutions. We use tools and guides to align the components to the patient's alignment. We look at anatomical axes, mechanical axes. Then we have intra and extramodality guides. There's the different balancing techniques, whether it's measured resection or more soft tissue driven alignment and balance. And we have found that the patients that has the best pain scores and has the best longevity of the implants would be patients that have their constitutional alignment respected. So if they were slightly bow-legged before they develop arthritis, to give them back what they had and not try and make their legs straight. And also people with a subtle knock-knee deformity, not to try and make it straight, but to balance their intact soft tissue or collateral ligaments, because that also helps you align the patellofemoral joint, which is crucial. Now, whenever you start one of these knee replacements, you either have to start with your tibia osteotomy or your femoral osteotomy, and then from there on, everything builds up from that platform. I start my knee replacements and on the tibia side, measure my anatomical axis on the tibia and decide how many angles I want on my proximal tibia, what slope from the front to back, and then I start balancing my knee to have it balanced through a full range of motion and allow the patella to track. So now these things get more and more complex, because when you do your tibia osteotomy and then your femoral osteotomy, then you go take your femur, that affects your patella tracking. If you have malbalances and you start releases, then it influences the whole stability of the knee. So we now have navigation and robotics that helps. I have been involved with navigation for the last few years, and now do all my knee replacement surgery and hip replacement surgery with the help of computer navigation. This enables me to accurately execute what I plan. So I would have this computer screen in the operating room. I would have pins with GPS trackers on the tibia and the femur. I would take the knee through a range of motion prior to doing any osteotomies and cuts, and would also find the hip center, the knee center, and a few key marks, which will then show me the patient's alignment, balance, and I would then decide what I want to achieve, and I can then chase that plan right until I have the final components in. But these are just a few examples of what we see and how we can check what we would do when we do these osteotomies. So in hip replacement, also, you know, a beautiful history over many years. Everyone in medicine will know who Sir Charlie is. He was knighted for the most successful surgery 40 years ago. And I have taken out numerous of his components 40 years after they were implanted. I have examples that I could show you later if you're interested. We now evolve to uncemented procedures as well, with different bearing options, different offsets, multiple sizes. This is the Brain Lab navigation system that I have in the operating room. The little green, yellow thing there with the eyes picks up the GPS trackers, and the screen will show me my offset and leg length, my cup position, and my neck resection levels. Whether the patient is lying on his back or on his or her side, it doesn't matter. You have these fixed points, and you can check that you don't shorten or lengthen the patient's leg. You don't increase or decrease the offset any more or less than you plan to do with your preoperative planning. There's kind of a simulation of how that would look. And as these programs evolve, we will shortly have our preoperative template and planning on the computer screen, which will then show us directly how we match our planning. So this is kind of what we can see. There will be more evolutions. We can now do this intraoperatively, where you can attach these GPS trackers to your reamers. With the robotics, you can preset where you want to ream, and the robot will stop reaming if you reach an area where you didn't plan to ream. Very exciting stuff. Fabulous to do. There doesn't go a week by that I don't tell my assistants or my team members, man, it's fantastic to do complex hip and knee replacements with this type of support, this technological support with these variety of implants and tools to use that we just couldn't do years ago when I did my training. So my bigger goal is to find young people that have anatomy and biomechanical disorders that will lead to arthritis. Now, the people in Switzerland and now in Boston and New York and Los Angeles, all over the world, has clearly showed us parameters that we can go by, measuring the degree of hip dysplasia, where we can tell patients if you have this degree of hip dysplasia, you will get arthritis when you get into your teens, when you get your first baby, or when you go into menopause. We also have parameters of degree of impingement, different deformities that would give you a deep socket or malpositioned socket, an abnormal torsion on the whole hip joint. And the principle is to get a well-balanced joint that doesn't impinge and that has healthy forces over the cartilage. So thank you very much. Be happy to answer any questions that you might have.
Thank you, Dr. Akermann, for a very insightful and informative talk on orthopedic surgery. I will just ask a couple of questions which was sent through prior to the talk, and if everybody has any questions, you're welcome to send it through the chat function. One of the questions was regarding orthopedics, and someone asked, what was appealing to you about orthopedics, and what would you say to a medical student who is interested in specializing in orthopedics one day?
So I think the appealing thing of orthopedics is that you really make people better. You take their pain away. You offer them good function. A lot of the procedures that we do in orthopedics, and especially in joint replacement surgery, is very reliable and reproducible. And as our field evolved, we have scientific data that enables us to tell people you have arthritis and knee pain or hip pain. I can give you 99% odds that a hip replacement will take all your pain away, allow you full function. Your hip replacement will feel as though you have a normal hip. Where a lot of other specialties, would perhaps save a life or prolong life for a little bit. The function might not be much better. And there's other specialties which would be more risky, where you would tell people the success rate would be 70%. For instance, spine surgery, if a good spine surgeon would counsel and interview a patient that needs a back operation, the statistics would tell us that 70% of these patients would be happy. Now, if you work for 20 years and you do 200 cases a year, after 20 years, there will be a lot of unhappy patients coming to your office. So young people that consider orthopedics, I think it's very hard work. It's long hours. It's challenging work. But if you're not really into it, you shouldn't go there. Like, there's easier ways to make money. There's easier specialties. But I think if you do rotations to orthopedics, you like the ambience of what orthopedic surgeons do, and you're willing to put in hard work, I don't know of any more rewarding career in the world.
Thank you. A lot of our readers were interested in your fellowship in the USA, and one of them asked, what made you decide to do your fellowship abroad instead of in South Africa?
I think I have to be honest every time with patients and you, because I'm not going anywhere and people come back and I have to tell the same story every time. So it wasn't really that I chose to do it abroad. We moved to Canada, me and my wife. She was a young physical therapist. And after 3.5 years in general orthopedics, I reaffirmed that my biggest passion in orthopedics, although I really liked all orthopedics, was hip and knee replacements. And I wasn't well trained and experienced in revision surgery, the more complex procedures. So I felt it necessary for my patients to equip myself with the knowledge and the skills to do really good hip and knee replacements, but also then be able to revise the hip and knee replacements when they need to be revised, when there's complications. And I then lived in Canada. I didn't even know that there was fellowships available in South Africa at that stage. I applied for probably 50 or 60 universities. I got invited to do interviews at 3, and I was just blessed to get the position at the University of Washington in Seattle. And it's typically a 1-year fellowship, but after the 1 year, my mentors enjoyed me and my South African training and the way we could work together. And in a way, I was a bridge between the two mentors, and the whole department worked better together, and they doubled my salary and kept me on for a second year. And so, yeah, it kind of happened.
Thank you. And then another person asked, since you have practiced professionally abroad for many years, what would you say the advantages are of working overseas, and equally what benefits lie in practicing in South Africa?
You know, I practiced in America for 1 year in a university town in Western New York, and I did my fellowship in Seattle for 2 years. And they have a fairly similar system as we have in the private system in South Africa. And then the rest of my time I worked in Canada, and the last 16 years in a larger center where it was more like the government system in South Africa, or the public system. So although I worked as a private contractor for the British Columbia government and was paid for the service I render, so per case, 90% of my cases were done for the province. And so it was like working at Tigerbird. So we got paid less per procedure, but we did a very large volume. And the system there wasn't as free as we have in South Africa now to evolve and investigate new technologies and newer procedures. So in South Africa, I've never been as happy working in orthopedics as I am now, because I can see Table Mountain out of my office window here. I live right on the ocean, and the weather is fantastic. And professionally, I work for myself, and I really don't do any parts of orthopedics that I don't like to do and that I don't feel I'm well equipped to do.
Okay. And this is a popular question amongst our members, but what kept you motivated during your life in university?
I think I put myself to medical school. So I worked holidays to pay for my tuition. I didn't have a bursary, and my parents couldn't fund my studies. So I worked to pay my university bills. So I needed to pass, otherwise I wouldn't finish. So I think that was the big motivation. And it would be really expensive for me to fail twice, then you're out, and I didn't know what else I would have done. So I think the motivation in medical school wasn't that hard, and it's interesting. Like I don't remember any dull times or stuff that I didn't enjoy. And the same with orthopedics. Like when I started doing orthopedics, I was caught up in the world of orthopedics, and I didn't need any special motivation tools.
Thank you. So now moving on to the questions I was sent through via the chat. You've mentioned the use of robotics for arthroplastic procedures. Where else in orthopedics can robotic surgery be used?
I think it is busy evolving in such a way that I would be able to do it in my joint preserving hip and knee surgery as well. At the moment, and I think unfortunately the way it works with industry, the money for the evolution of these expensive equipment needs to be sponsored by industry, and joint replacement components are expensive. But we use more expensive equipment and ankles in labral repairs and osteotomies as well. And I think more and more people make partnerships with surgeons So they would be interested in, being a part of the expensive part of their practice, like joint replacements, but also in the less expensive part of their practice, like joint preserving surgery, where you might use 2 screws and a few ankles to repair the labrum. So I think it is evolving now. I've got a journal from 1997 where Professor Gans and his team were looking into robotics with periacetabular osteotomies. But there was no one and no industry willing to put up that amount of money to evolve that into procedures that couldn't make their money.
And then I think we have time for one more question. What would you recommend students do leading up to their internship to improve their chances of getting into orthopedics?
I think first and foremost, they need to do well. So I reconnected with the Tygerberg Orthopedic Group with Prof. Heike de Tooy. You guys really have a state-of-the-art orthopedic department there. I think it's rated #1 in South Africa, if not Africa, at this stage. You guys do more research than any other university in South Africa in orthopedics. It's currently the #1 orthopedic department when people apply for residencies, and they look at marks. So you need to be smart, work hard, get really good marks. And if you do research and you write papers, that will be a good supporting way of getting in. And currently, Prof. Heike and his team doesn't even look at resumes if you don't have your primary exams and you're a good way with your research project.
Thank you, Doctor. And on behalf of SAS, we thank everyone for joining us today on this lovely summer's day that we have. And yeah, thank you for everyone coming, and you may leave the group. Thank you, Doctor.
Thank you.